All right, let's start. Hi, everyone. My name is Françoise. I'm the president of MDM, and I'm delighted to be welcoming you all today for this 10th edition of the Scientific Day of Humanitarian and Solidarity Health. Thank you so much for attending. There are many of you today. I can see a lot of people online as well. And so this day is organized every single year in partnership with the MDM Foundation, which is also celebrating its 10th anniversary this year. And I would like to thank them for their action and their support. Thank you to the president of the foundation celebrating its 10th anniversary. Please, a round of applause for them. They are extremely important, of course, for our projects, but also for advocacy work. This is the third time as well that we are in l'Auditorium du Monde, and I'd like to thank the team for welcoming us. MDM is an independent, impartial, and militant international medical humanitarian association that has been fighting against inequalities, against health, social, environmental inequalities for nearly 45 years. We operate in France and in 30 other countries. And of course, we're extremely committed when it comes to research, especially operational research. This is not an empty word for us in our association. Of course, we attach crucial importance to it. Insofar as the knowledge produced, acquired, and analyzed has a decisive impact on our interventions and our advocacy. So in this respect, the annual Scientific Day is an important forum for learning and cultivating constructive, critical thinking about humanitarian knowledge. And today is also an opportunity to highlight the results of operational research and innovations from MDM's field projects and other partner organizations, of course, based on scientific evidence. And so we have partners in France, but also on the international stage. So over the course of the day, the speakers will be putting forward suggestions and recommendations designed to enrich, improve, and hopefully strengthen our capacity for action in the field. So proceedings will be drawn up following the event, and they will be made public. Of course, this will be open source content. This year, we are going to be looking at humanitarian action and knowledge in the face of populism. This is going to be the red thread of our day. And so we'll be looking at ways of continuing our work with the most vulnerable populations in context increasingly marked by the rise of extremes, but also by the restriction of official development aid and the increasingly hostile media and political environment towards humanitarian actors. Today will also be punctuated by 2 roundtables and 2 conference debates with subjects such as access to rights and healthcare for exiles and the myth that surround them. But we'll also be talking about the perpetual struggle for effective and safe access to abortion. And we'll also, of course, be talking about the role of humanitarians in a context of democratic progression. So some practical aspects that I'd like to highlight or underline for you. All of the discussions can be followed in French or in English. You can also follow them whether you're online or attending here in this room. You do have headsets at the entrance of that room for translation if you ever need it. At the end of each session, there will be time for questions, so do not hesitate to submit your questions and or comments. You can either ask your questions directly in the room, or you can just write your questions directly in the chat. Please feel free. We'll be happy to get your questions, your contribution, comments, and so on. And of course, a replay of this entire day will be made available. We'll also have an association village that will be set up during lunchtime to enable direct contact with associations and collectives that are usually working with us in the field. Finally, we'll have a drink to conclude this event, so from 5:15, so in the same space as the one that you'll be having lunch. And of course, this will give us an opportunity for further informal discussions. So to conclude this introduction, and in order not to take too much of your time and move on to the first roundtable, I'd like to share with you a very short video about research at MDM and about the 10th anniversary of the Scientific Day. See you in a minute.
L'action de Médecins du Monde, que ce soit auprès des populations ou en termes de plaidoyer pour des politiques publiques qui répondent aux besoins de santé, s'appuie sur les savoirs scientifiques afin de s'assurer de la pertinence et de la qualité de nos interventions. Faire de la recherche opérationnelle n'est jamais simple. C'est un enjeu de temporalité, de ressources, éthique, mais nous avons toujours réussi à faire de la recherche un levier essentiel de transformation sociale et politique via nos actions. nous ne sommes pas seuls dans cette démarche. Si les recherches nous ont permis de mieux faire, de générer de la transformation en faveur de nos combats pour plus de justice sociale, c'est aussi grâce à la collaboration, au partenariat scientifique et à la participation des personnes concernées. Maintenant, mes collègues Anne et Ernst vont vous présenter 2 histoires de recherche qui ont été marquantes pour nous.
À partir de 2014, à la suite d'un engagement de Médecins du Monde en faveur des droits en santé sexuelle et reproductive, nous avons conduit des recherches en sciences sociales sur les déterminants socioculturels des grossesses non intentionnelles sur plusieurs terrains d'intervention à travers le monde. Ces recherches ont nourri nos activités programmatiques et nos plaidoyers pour un meilleur accès aux soins et aux droits en santé sexuelle et reproductive. Au fil des échanges, avec nos équipes sur le terrain et les chercheurs, on a mis en place une recherche opérationnelle sur les avortements clandestins et leurs conséquences en Côte d'Ivoire. Ce travail a abouti à des cadres opérationnels pour l'accès à l'avortement et sur des notes de plaidoyer utilisées sur l'ensemble de nos terrains aujourd'hui. En parallèle, on a aussi conduit des recherches opérationnelles en sciences sociales et en épidémiologie, accolées à nos projets de prévention et de prise en charge du cancer du col de l'utérus au Burkina Faso et en Côte d'Ivoire. Ces recherches ont permis de démontrer qu'un nouvel algorithme de dépistage était efficient, coût-efficace et possible à mettre en place dans les systèmes de santé de ces pays. Grâce à la conduite conjointe de programmes pilotes qui testaient cet algorithme et l'évaluaient à l'aide de la recherche, nous avons pu construire des plaidoyers forts qui ont abouti à sa mise en place et à l'évolution des protocoles nationaux. Aujourd'hui, le combat se poursuit en associant activités de terrain, recherche et plaidoyer afin de répliquer ce modèle et de le mettre à l'échelle au niveau national dans plusieurs pays.
Médecins du Monde a développé une expertise dans la prise en charge des populations clés comme des usagers de drogue et des travailleuses de sexe criminalisés, stigmatisés fortement. Nous utilisons une approche de réduction de risque qui implique une grande application de populations clés. Notre programme s'adresse à les problématiques locales, mais pour but d'innover et de ramener de nouvelles données et de nouvelles recherches qui a pour but d'influencer des protocoles internationaux. Les usagers de drogue ils sont particulièrement touchés par le VIH et l'hépatite C, donc notre programme s'adresse à ces problématiques, mais nous avons développé une expertise spécifique sur l'hépatite C. Le traitement d'hépatite C a révolutionné il y a 10 ans et nous faisons partie des premières à mettre en place des programmes spécifiquement pour les usagers de drogue de traiter l'hépatite C. Les résultats de notre recherche qui ont été menés dans plusieurs endroits dans le monde ont vraiment influencé les modèles actuels reconnus et les algorithmes de traitement de l'OMS. Nous continuons à faire de recherches sur l'hépatite C, actuellement en Tanzanie, Géorgie et Arménie. Grâce à notre reconnaissance et le grand travail dans le terrain, nous avons la chance de travailler avec les équipes les plus reconnues mondiales sur ce sujet et continuer à influencer les protocoles et les recommandations de l'OMS.
Il y a 10 ans, l'idée des journées scientifiques est née de la volonté de créer un espace de discussion entre chercheurs, acteurs de terrain et décideurs afin que les actions humanitaires et de santé publique soient basées sur les savoirs pour renforcer la qualité des pratiques, l'adaptation des politiques publiques et tout simplement pour répondre au mieux aux besoins de santé des populations en tenant compte de leur réalité et de leur vulnérabilité. Au fil des années, ces rencontres ont permis d'explorer des thématiques clés. Par exemple, nous avons interrogé l'éthique de la recherche, essentielle pour garantir des pratiques respectueuses, responsables et intégrant la perspective des personnes directement concernées. Nous avons également débattu de l'influence de la recherche sur les politiques publiques, soulignant son rôle dans l'orientation des décisions stratégiques. Notre ambition aujourd'hui, et encore plus face aux enjeux de l'actualité, est que cette journée favorise les échanges constructifs afin de faire émerger des idées innovantes en faveur de l'accès aux soins et aux droits pour toutes et tous.
Merci au service de la communication.
Thank you to the communications team and to all of the teams that have participated in that video. It was a perfect sum up of the 10th anniversary of the Scientific Day. Thank you so much to everyone. I also want to thank in advance all of the speakers that we're going to have today that are working with us for the Scientific Day. You do have the agenda for today in the notebook that was given to you. Thank you also to the MDM teams who have been working on this program for this new edition for several months now. So we do have a committee organizing discussions so that we can prepare and organize this day. So thank you to MDM for this amazing agenda for this new edition. And also, of course, thank you to the technical teams who make it possible. And I'm not forgetting you, the ever-popular audience. There are more and more of you every single year. Thank you so much for attending, and have a great day ahead. Enjoy. Well, hi, everyone. I am going to welcome everyone on stage, but I'm going to introduce myself first. My name is Françoise Sivignon. I'm a doctor and a vice president of MDM, so I'm not going to be telling you about the logistics aspects that Jean-François has already mentioned. I just wanted to say that we all need to make sure that we don't speak too fast, because we do have interpreters with us today. So if you have a headset, if you don't have a headset, you might want one, because we do have a speaker that will be speaking English, and I know that online you already probably have chosen your channel. So we'll get straight to the point. So as a solidarity player, but also as a citizen, we do have a role. So, of course, Stand Up for Science is a movement that we all know. And so today is the perfect opportunity to show how attached we are to knowledge transmission. So knowledge has to be defended. It has to be defended as a common good, and institutions such as universities are pillars of democracy, and this is why we've gathered the three experts that will be participating in that round table. So today they are going to talk about what it means, what this title means for them. So the title of this round table is Health and Migration, Dispelling Myth, Guaranteeing Rights. So the myth, I think you all know them. The myth of invasion, with migrations that are so important, that are threatening jobs and social services, and also the myth of immigration, such as being a cause for insecurity. So we will also talk about what it means to guarantee rights, namely the asylum right, but we'll also be talking about the legal framework in the UK and in the EU. Migrants that we support in many different projects that we have in MDM are victims of repressive measures, and they're mistreated during the entire migratory journey, but also once they've reached their destination in their host country. Of course, this has dramatic consequences on their health, but also on their access to fundamental rights. So to talk about this, I'll give the floor to three different speakers. The first one is on my left. Her name is Camille Gardesse. So Camille, you're a sociologist, and you're also a town planner. You're a lecturer at the Paris School of Urban Planning, Paris East. You also work at the Urba Lab and Convergence Migration. You've worked with MDM in partnership, and so you've worked on mental health resources for vulnerable people living in exile. And so the idea is to get some of the lessons learned in the continuous consultations for mental health with MDM. So your work through an ethnographic was made through an ethnographic study, and so the idea was to understand the impact on people living in exile and the impact it has on their mental health. And we talked of what it is to be in a host country. So we'll start with a first question regarding the distress of people living in exile in Paris. And so the idea is, why were they coming to see you at this psychic or mental well-being continuous consultations? Well, hi, and thank you so much. I'm delighted to be here with you today and be able to discuss with you about this very interesting topic. Maybe just a few words regarding the way that I've worked, because this is a research action, even though I don't really like this term, but we've worked with the Psychic Continuous Consultation Center for people living in exile. So we work together when it comes to structuring this research project and having to looking on things that could just come and feed that research or that project. So this is something that we've done in two different parts. So, we've done an immersion phase. So I was a volunteer within this psychic permanent consultation, but I was also doing research on a few points. So this is something that I've done at the Paris Scale, and the idea was to try and map out everything regarding mental well-being. So on people living in exile. So I just wanted to say a few words about, the way that I've worked and how I've organized my work. So why do people come to this mental well-being or, psychic health consult? Well, you probably know this better than me, but the first thing that people talk about would be their symptoms. So having trouble to sleep, having somatic issues, that we're not able to identify what's the cause of that symptom. And we also have anxiety disorders or depression disorder. And we also have a lot of PTSD for most people living in exile. So, of course, if I'm talking about this first, is because one of the first counterintuition, if we can call it that way, so in that research here, is that it's not much about trauma or experiences lived before arriving in France, that they talk about when they come and see us for a consult, but they actually talk about their current living conditions in France. So at least in what they tell us, in what we're talking about, they always mention their living conditions, their current living conditions first. So this is the reasons why they come and see us in the first place. So it's about their urban experience, so their living conditions in Paris that are also in line or impacted by migration measures. Because when I'm talking about urban experiences, of course, people are in a very vulnerable situation. They don't have a specific housing. They live in the streets. Or they just live in the street for a while, then they're hosted somewhere, but they always end up going back to the street and so on. So, this is, here I'm talking about Paris, but this is pretty much the same in other cities as well. You have some sort of a cycle in which a camp is being set up and then the camp is being dismantled, and it's a cycle that goes over and over again. So, of course, it means that people are always on the move, but always on the move within the public space. So either you have you've got the police that intervenes, sometimes quite violently, or we do have some town planning that is quite deterrent. So you've seen that in Paris, for example. So you do have you've got fences in some places, or big rocks, or maybe some urban furnitures. That you would think that this is to make the city look better. You've seen, for example, for the games, there are some picnic tables that were set up for the games. But, the camp was dismantled right away once everything was set up. So we know exactly why these furnitures were installed in the first place, of course. So what I mean by this is that people are basically always on the move. They always have to look for somewhere else. They are made invisible. They always have to try and find some hidden places where they can set up their camp. And of course, they're under a lot of pressure, so they have a lot of stress, a lot of anxiety. If we think of the police, for example, people talk about the fact that they're not able to sleep, right? And the lack of sleep has huge consequences on health and on mental health. So if we look into the reasons why people come and see us, so we see that the fact that they're always on the move, this is something that always comes up. So this is a major factor of stress, because they are sleep deprived as well. They don't have the money, for example, to pay for a bus ticket, but they're also scared to be controlled and then end up at the police station. So we have people, for example, that are not able to come to see us because they're just afraid that they might be arrested on the way to our center. I mean, of course, MDM is giving out bus tickets whenever we can, but this isn't something that we can do on a daily basis every single time. So, it may be a bit counterintuitive, but I think it's really important to understand that this mental distress or this you know, it's linked to all of the different administrative measures that are being implemented. This is linked to the living conditions, the current living conditions of people living in exile, because the measures are creating this situation, is creating this context in which they live. So, of course, this has an impact on their urban experiences. Of course, the admin process is a factor of stress. Those are not measures that support people. I'm thinking of asylum, for example. You might have people that have to go through their trauma over and over again in their asylum process. So here we're talking about people that are always suspected to be lying. They're always suspected to want to try and cheat their way into the country and so on. And then I'll stop talking because I know that I'm talking too much. But you know, this precarious conditions, the fact that we're not welcoming people living in exile, of course, it creates mental distress. But to go a bit further than that, it also hinders us to treat PTSD that are linked to the experiences they lived before coming to France. So this is what psychologists and psychiatrists have explained to us, and this is something we can see in the field as well, and they insist on that. You know, this is a phrase that was told to me, like we try not to open the Pandora box of trauma, because when we're facing, especially when we're facing patients that, you know, once they are done with the consult, we know that they will go back to very dire living conditions, whether, you know, physical, material, or psychological conditions here. So, of course, this is important to take this into consideration. I mean, if you have patients, they need to talk about their trauma, they need to talk about the violence they have been through. Of course, we'll listen to them. But what it means here, to try and put it in other words, is that, you know, the social aspect takes all of the space in the consult. So in the end, we don't really have enough time to try and treat PTSD. And there are other research on the topic. I know that MDM has supported projects like this when it comes to violences through the migratory journey. And, you know, it's quite terrible to think that living conditions and the migratory policies and measures, you know, they have an impact on that. But also, it's just hinder us from treating the pre-existing traumas. Thank you so much. This was fascinating. We'll probably talk about this a bit more later on. But I just also wanted to ask a question regarding the challenges and obstacles to have access to mental health. I mean, what are the modalities? What are the limits? Camille, can you tell us a bit more about this? Yes, of course. Again, I've worked in the Paris area, or at least, you know, the cities that are very close to Paris. But this is a territory in which we have the most resources as well, right? And if we look at the map here, we can see that we have different modalities of doing things, different treatment modalities as well. And what we hear about within our team is that it's never enough when we look into the real needs that we have. So maybe, you know, the offer seems to be quite broad and important, but it's still not enough if we look at the demands that we have. We should be able to ensure first access to health, especially for these people living in dire poverty and live in exile. What it means is that all of our structures are basically completely overwhelmed. And there's one thing I'd like to insist on, and I'm thinking of MDM and others. It's almost impossible to refer people to common right because there is a lack of public services. So, of course, in general, the psychic and mental health department, you know, is not in such great condition either in the country. But this is still a challenge here because we cannot delegate. I mean, the state cannot delegate to associations. I mean, of course, associations are doing a wonderful work, a wonderful job here. But then we do have disparities in between different facilities here. And, you know, one thing that this is quite recurring actually, but we have something specific here. We've got a clinic and we've got an exile clinic. There is a PTSD clinic as well. There is a clinic for dire poverty. And so those different clinics, if you will, are just working together, and they do something a bit different than what psychologists and psychiatrists can do. So we have to diversify when it comes to the different care that we can provide. They're also adapting to the living conditions of the people they're trying to treat, and trying to adapt to their challenges. So a lot is at stake here, you know. Health professionals are extremely committed. They're always trying to adapt, always trying to find new ways of caring for these people. And I think it's really important for them also to have this sort of a cross-disciplinary approach in their work. Working in teams and having these cross-disciplinary teams, so having, for example, legal workers, but also GPs and social workers. So if you have a diversified team like this, you have more of a global approach. And so it means that during the consult, you have enough space for everything. So there are more and more initiatives as well that are being implemented by the different actors in the sector. I mean, of course, the needs would be to have more means, but it would be also important to have discussions in between health professionals, so within the same facility, or maybe at an even bigger scale, just for health professionals to be able to share their experience and discuss a bit more. And I just wanted also to sort of quote a psychiatrist of the MDM Foundation. She always says, there is no care without hospitality. And this is something I've been able to observe myself. So we do have care facilities where you can have help when it comes to mental or psychic health, and so you do have people, for example, coming to this continuous consultation center. So this is some sort of a shelter as well. They can rest. They can stay for a little while. They can be outside of their dire living conditions, and so here we of course want to give them a space in which they can talk. And so this is something we're trying to implement at the moment. So this is psychosocial care basically that we're trying to offer. And I know that I need to speed up a little bit, but to give a few words regarding interpreting, because we know that it's extremely important. We have interpreters 24/7 in our consult center, and I was telling you about additional means for other facilities. I mean, of course, interpreting, that it's expensive, so this is one of the main budget lines, but this is essential. We could say many things about interpreting for sure, but I think it's extremely important to take this into consideration, because interpreters, when they're working in this therapeutic aspect, they're not just translating words. They're doing mediation. Mediation is extremely important, cultural mediation, and so of course this forces us to rethink what we do. Of course, this is not usual. We don't have a third party here in the middle doing mediation when we do consults in general. So this is also a different way of working, but this is extremely important to have the interpreters, because this also reassures people living in exile. Thank you, Camille. It was very clear. And you're right on time, so no stress. I do have a timekeeper showing me a panel board, but that's fine. I mean, if we talk about myth, or if we talk about preconceived ideas, we can see that the experiences that people went through doesn't have a bigger impact than the dire living conditions they are currently. So you've said this is a hostile environment. You talked about urban violence as well. You talked about the fact that social issues usually are taking all of the place. Taking all the space, when we're doing a consult. So you're able to always treat PTSD, for example. And also, of course, I read your work. And as you said, there is no care without any hospitality. And I think this is, the words that we need to keep from your first intervention. I'm hoping that you'll get a lot of questions. And so now, we talked about the space, and this is also what Daphne works on. Daphne is our second speaker. Daphne Velay, you have a master's in international law. And you work on what is happening at the border in between France and Italy. This might be complicated to translate into English, but they will find a way. So this is called Briançon Migration Control Measures, an investigation into the spatial legal mechanisms involved in the Haute-Alps border. So this is about deploying a mechanism in which you have border controls, because the border was reinstated back in 2015 when we had a political and migration crisis, and more specifically during your thesis, so in between 2021 and 2024. In your thesis, you talk about geography. I mean, you are an expert in geography, and you will tell us a bit more about geography and the police forces, actually. And you'll be telling us a bit more about the law as well in this very specific area. So I'm going to give you the floor by asking you a first question.
In the border area of Briançon, which you're familiar with and that people in the room here know, how do you conceive care and health for people in migration? Thank you, Françoise. It's difficult to synthesize my thesis, but before I dive into this topic, I'd like to first talk about my research. So I focused on the region of Briançon. As you probably know, controls have been strengthened by France starting 2015 between Italy and France in the Alpes-Maritimes region, and then later on 2016 and 2017 around Briançon, so in the Hautes-Alpes region. And at the same time, this region has observed an increase of exile, people in exile from central Mediterranean, from the Balkan through Trieste, so the northeast of Italy. Then from Italy, people tried to enter France through the mountain. They have to go through a high mountainous path at night to avoid border controls that are targeting them to send them back to Italy, using procedures that are against the law, really, and that were that in April 2024 it was regulated. Olivier Clochard and Philippe Lagrange have been following my work and supervising me, and I've been working in my study on this border point to understand the momentum in the creation of this very specific border area. So part of my thesis is really focused on access to care in this border region. And the goal is to challenge how care and health-related issues in rescue can interact with border controls. Just so you know, I'm actually working with the MICMAP team with Dr. Nova. They're based in Grenoble. And we've tried to come up with visuals to make it more visible and to make people understand where these controls take place. So this is my study. I really worked on based on a 3-year contract within the legal department of the association, the organization Tous Migrants in Briançon, in partnership with Médecins du Monde. Médecins du Monde is present in Briançon, has been there since 2017 rather, to reduce risk, health, psychological and physical risks for people in exile, with a medical care consultation within organizations so that people can rest 1 or 2 days before they go on in their exile journey. And this consultation takes place with the PASS within the Briançon hospital, and Médecins du Monde partook actually in the creation of the PASS. Médecins du Monde also has a mobile shelter system in order to care for the people in the mountain and reduce risks that are taken by the people who are crossing the mountain. You have an example here of a brochure to raise awareness based on a small qualitative survey that we've conducted in order to see the impact of this crossing on people's body. As part of my PhD research, I was able to sample qualitative data, a large area of qualitative data within the Monde team. So people who were static, but also who were hiking on skis as well. I was able to interview different people in exile, people who were rejected and taken back to Italy, border police, the population, members of organization, and then I've also analyzed legal documents such as individual process documents, documents from the administrative court of Marseille, and the rights defenders. So people in exile are submitted to a regime that would mean that they should never enter a territory. So they have to walk for hours and hours on end in difficult conditions, especially in the winter with the snow in the mountain, but also in the summer. People go into the mountain further because there's more visibility, but they could get lost, and there is a risk of dehydration. And the data collected by Médecins du Monde show that the large majority of reasons why there are consultations are actually related to the crossing itself, the crossing of the border, but there are also chronic diseases and infections more related to their journey in exile. We also have people who have frozen limbs that could have disastrous conditions and implications for people. Last February, someone was taken to a hyperbar box in the Lyon hospital where that person was amputated, got some toes amputated. So to avoid this risk of frozen limbs, Médecins du Monde is raising awareness amongst the solidarity shelter. So they give hot water bath to people's toes and fingers to prevent this. And the one thing that I really wanted to insist on is that the restrictive policy that's applied in the Italian and French border does not prevent people from crossing. This is clear. This is one preconceived idea, but that's not true. It actually simply increases the vulnerability of people, because what you need to understand is that the border is the exact place where a state wants to enforce control. We've seen it with Elisabeth Borne's announcements in 2023 with the border force in the Hautes-Alpes and Alpes-Maritimes, and in November 2024, the Prime Minister and Bruno Retailleau that came there to announce the fact that they were taking over the migration and control issues. And when I spoke to police enforcement, they said that they had doubts about the creation of these initiatives on a political standpoint. These are just mere announcements to give momentum to something that doesn't really lead to anything. So I was talking about frostbites earlier when I was talking about frozen limbs. So about the risk and the danger taken by the people that are trying to cross the border. Sorry, I need to put my glasses on. There you go. So, in this condition, what is the place of rescue, risk, and danger in the humanitarian response and in the police forces policies? Well, in this kind of border area where you have a very strict policy, there's a humanitarian dialectic that takes place, and it's really the case there, especially because here you're in a mountain area, so you're at height, you have heights, you have ditches, you have the weather, you have snow, and the prefecture is actually using this to transform it into police raids to control people, into rescue missions. And we realize that the notion of danger at the border is actually used abundantly, and pretending that they're going to put the people in exile in a safe place, but when the people are actually arrested in the mountain, they're taken to the police station or in a temporary building next to the police station. It's considered a shelter, but it's actually also a place where they're deprived of their rights, and it has an impact on their access to rights. So this mission where they say that the prefecture is saying that they're going to put these people in a safe place is can be challenged. So even when the people say that they want to see a doctor because they're hurting or they have a disease, it's up to the police officers to decide whether they will give access to a doctor or not, even if the person's been spending hours and hours in a mountain without specific equipment. And the police force's ability to assess frostbites, or because it requires some time and capacity to assess frostbites. And there are different criteria that should define and that don't really define, they're not clearly defined, that should trigger a call to health centers, and that's not been really defined. And the detention of people up until February 2024, which was when the Council of State was clarified the definition of and the criteria for detention at the border. Now it's an administrative process that has been formally defined, but before that it wasn't the case. And within that time frame, they should have access to a consultation with a doctor. So now at least it exists. And the Monde collective was created in 2016, and LUMA, so mobile unit for sheltering, that was starting in 2017 by Médecins du Monde. They now have a car with a Médecins du Monde logo, and they have people hiking the mountain on the French side of the mountain in order to offer help to people in exile with food, a shelter. They can also take them to the hospital if necessary. So just like in Calais or other borders, this humanitarian action is hindered by intimidation from the police with stop and frisk, intimidation, fines. Tous Migrants, l'ANAFE, Médecins du Monde have called upon the human rights defender in order to signal, to notify of these violations. In the Maraude, the position of the Médecins du Monde caregivers is quite specific, because the fact that they're putting these people in shelter is really based on their professional capacity. But if there's a control by the police, the decision of the caregiver can actually be challenged or ignored by the police forces. When the police forces can stop the people, even when they're in a Médecins du Monde vehicle, to send them back to Italy. It happens mainly to nurses, who often see the police discredit their diagnosis. So there's a power imbalance, and that's at the heart of the negotiation and the vulnerability of people in exile. And this is determining for people, because the result of this negotiation then decides whether they should be sent outside of the French territory or not. And on top of that, the Médecins du Monde's position is clear. We want to make care spaces sacred, including these cars, including these vehicles. And the humanitarian argument is used by Médecins du Monde in different ways. Someone who's in a mountain at night without equipment is de facto vulnerable and therefore requires real sheltering. Thank you very much, Daphné. I'm turning to Sophie. I think we have a few more minutes to answer one third question, maybe. What about the role of the Briançon Health Centre In a few minutes, absolutely. Well, Médecins du Monde partook in the creation of the pass in 2017, so access to care is free. In Briançon, the hospital is located 9 kilometers away from the border. What's complicated is when people are directly directed to the hospital by the police from the border. When the police calls the SAMU or the firefighters to send these people to hospital, you have different situations that can happen. In most cases, people are freed and released after the firefighters, after seeing the firefighters in the SAMU, the hospital. But sometimes the police wants to keep control and maybe come back the next morning to get information about why that person went to hospital or what time that person is going to be released, to take that person and send them back to Italy. And there could also be tensions between hospital caregivers who refuse to give that kind of information because this is medical secrecy, as you all know. And my hypothesis is that this is at the intersection of space and right, because up until the 2024 decision, the fact that there was no legal framework for the detention at Montgenèvre on top of the location of the border has created this grey area, allowing people to, or the police to mentally locate the border between the actual border and the hospital. This created this very large border, and this opacity, legal opacity, has led to the reduction of the capacity of hospital caregivers or management of the hospital to oppose these illegal decisions and practices. Thank you very much. This is very interesting. This is indeed a specific border. This is a very interesting space, topography that's really interesting. Going back to what you said, there's a clear solidarity network and a lot of activism, a lot of organizations. And this is a space that is really engaging for us at the Italian-French border. We also have mobile solidarity units.
Particulier et qu'on retrouve dans plusieurs programmes de médecins.
With outreach programs and this weaponization of political weaponization. The CNCDH, Human Rights Watch have produced reports pointing out these violations. And the criminalization of people who are helping people in exile. That's part of our program. So the space and transformation of space is the last topic with Anna Miller. Anna, you're in charge of strategy and advocacy within Médecins du Monde in the UK. And I'd like also to thank the members of the International Network of Médecins du Monde who are with us. We have more and more people attending our scientific days and other events, so we're really happy to have Anna with us today. Today you're going to be talking about a report, the title of which is Like a Prison, No Control, No Sleep. Where it talks about mental health in migrant retention centres in the UK. In 2023, the UK government has created this Wethersfield shelter in rural Essex. And in 2023, also in the UK, Conservatives that were still in power at the time had the Illegal Migration Act voted, which you may discuss in a minute. Thank you for describing your activities in the current context, in the political context, especially as it was at the time, because I think there have been changes since then. But I'd like for you to talk about the advocacy work that you've done with the authorities, with MSF. So with the decision makers that you'll probably talk about. I'd like to start with the first question. How does MDM UK, how did it use its advocacy work with the authorities, and to what extent did you succeed in this advocacy work?
Thank you. I will speak in English, I'm afraid. I hope that is okay. My slides are in French, so I hope that will also help you. And also, thank you very much for inviting me today. So I was asked to speak about a report that we have published in the UK that is based on a programme that we ran in 2024 at a site that we called Wethersfield. I'll explain a little bit more. Well, I will start by explaining what the programme was, why we went there, and then some of the evidence and data that we collected, and then I will move on to the advocacy work that we did. Okay, so first of all, to give you a little bit of background, this is the research and the MDM programme was carried out at a location which is called RAF Wethersfield. It stands for Royal Air Force Wethersfield. It was a military site for the Air Force in the UK that has been closed for a couple of decades. And in 2023, the UK government initiated a new policy to accommodate people who are in the UK asylum system, so anybody with a pending claim for refugee protection, to accommodate, to start to use disused former military sites as accommodation for them. And one of the sites was this site called RAF Wethersfield. It was opened in July 2023. Wethersfield is actually the name of a small village. It is a very rural part of the UK in Essex. So the military site itself is 8 miles away from a town. It's a very isolated location, and there is no public transport there. And even if you were to walk from the site to the closest town, there are it is small winding roads. There are not footpaths on the side of the roads. And actually, I can't do my slides back, but you saw the initial slide. That was a photo of Wethersfield. Because it was a military base, it has a very sort of military feel. It is surrounded by chainmail fences and barbed wire. There is security as you enter the site. The government policy is that the people who would be accommodated there, it would always be men. Women are not accommodated there, and children are not accommodated there. So it is men aged between 18 and 65, and the site has a capacity for 800 people.
L'action Médecins du Monde, que ce soit auprès des...
Okay. The UK Home Office, which is our government department responsible for the asylum system, the part of the policy was that former military sites would not be suitable for people who are survivors of torture or of trafficking, and those with the most serious and physical mental health needs. So right from the start, there was a recognition from the government that these sites had the potential to be harmful to certain people, and they defined who they thought that was. In reality, everybody who was accommodated at the site were people who had crossed the channel between France and Belgium and the UK by small boat with at the most a couple of months earlier. So it was very new arrivals and always people who had come by small boat. And as Françoise says, another really important context was that the UK government at the same time passed a bill that was called the UK Illegal Migration Act. And this meant that the act of crossing by the channel and arriving in the UK without permission barred you from accessing the asylum system. So I say this was accommodation for people in the asylum system, but actually it was accommodation for people who had been picked up by the UK government, had expressed a desire to make an asylum application, and under this new act were all going to be received notice that they were inadmissible to the asylum system. So this is sort of like pre-asylum system. So to tell you a little bit about our clinic, how we collected the data and what we actually found, we ran a primary care clinic just outside the gates of the site. It was a project that we did in partnership with MSF UK and MSF Belgium. And we used a mobile clinic, so we had our own confidential clinical space. The site, strictly speaking, legally speaking, is not a detention centre. So even though it is surrounded by barbed wire and chain metal fence, the men there are not detained. They are allowed to leave whenever they want to, but it's a sort of meaningless freedom because there is nowhere there is nowhere to go. But with us being there and us having the mobile clinic there, it did mean that like they had good access to us. Men could just walk through the security. They were not harassed as they left. They were able to access the clinic freely. So at the time that we published the data in our report, we had collected data from 122 people accessing our service. The average, everybody was male, of course. The average age of people accessing our service was between 20 and 29. The most common countries of origin were Iran, Eritrea, Afghanistan, and Syria. 68% of people accessing our service reported a history of violence. Most commonly, this was experience of living in a country with armed conflict or war, but also the other two types of violence that were quite commonly reported were experiences of torture and also experience of violence by police or armed forces. We screened people. We carried out mental health screening as people accessed the service, and 70% of people were screened as having severe psychological distress. We identified suicidal ideation or planning in 41% of people accessing the service. The most common diagnosis reported by the clinicians was symptoms consistent with PTSD. The common causes of distress that people reported, and this is a very strong parallel with what Camille was just saying, was that although, of course, the people we were seeing had huge histories of sort of trauma and bereavement and incredibly difficult journeys to the UK, but the issues that they raised most, their cause of distress, was the conditions in which they were living within the site. Particularly the isolated nature of it, the fact that it felt like a prison. Very often people would say to us, I didn't expect when I arrived in the UK to be put into prison. That was how people felt. Another major cause of distress was just not being able to get on with their lives. That was linked to it was a combination of being in such an isolated location, but also the fact that they were barred from accessing the asylum system. So there was a real sense of despair about what was going to happen. And also then another issue that came up a lot was a lack of safety within the site. There was a lot of inter-group, inter-ethnic conflict within the site. Eventually, we were shown videos often of very bad violence and fighting within the site. It was largely driven by scarcity of resource. To give you an idea, at meal times, the number of people there, you would have to queue up for 2 hours to get food, and sometimes the food would run out. So sort of like competition and tension around food was a huge issue in the site. And of course, like particular groups were, some groups were particularly vulnerable within the sites, like smaller groups. And often it were like, to speak frankly, it was racial tension. Black people within the site were very at risk. And I talked earlier about that the government had this own policy that they recognised that certain people weren't suitable for the site. Based on the data we collected from people we saw, we assessed that about 75% of people shouldn't have been in the site if that policy had been applied properly. So if people were being screened before they went into the site for history of torture, history of trafficking, they wouldn't have ended up there. And then if people received proper medical care and particularly mental health conditions were identified, they wouldn't have remained in the site. I would just very quickly just go through the conclusions of the report, like based on the evidence that we collected. So we concluded that the containment site itself was causing harm to people. And our recommendations based on the evidence was that the site was closed urgently, and that the broader policy of using remote military sites to accommodate people was ended, and that we were also in favour of people within the asylum system always being accommodated in dignified and community accommodation, and that was largely linked to having an environment for them that there was any chance of recovery, particularly from mental health harm and conditions.
Thank you, Anna. So what we can move on to the second question. Sorry. So it's about the advocacy work for your second question that you've mentioned it. How does this advocacy work was conveyed to the decision makers, and what were the results as well? Because they were very conservative at the time. So, you know, what results did you want? Did you expect? And what are the results that you actually got?
Yes. So really, we published the report quite early on. We published the report as soon as we felt we had sufficient data to talk about what we were seeing. We'll be doing a fuller, I guess, more robust scientific report now with a whole year's data. But we felt a real urgency that we needed to have some evidence base to be able to begin to speak out about what we were seeing at Wethersfield. And at the time, we had a Conservative government that was very focused on, I guess, essentially like the myth that everybody, particularly the sort of like anti-migrant agenda in the UK and anti-migrant politicians are, at the moment, their favourite topic is people arriving by small boats, that they are at best economic migrants, really that they are criminals, that they are dangerous, they are all men, they're not genuine asylum seekers, and yes, there's an element of invasion and great replacement theory to it as well. And the men that we saw at Wethersfield, those were the people who were the direct target of this myth. So we felt it was very important to, first of all, speak out and humanize these individuals. Something that surprised us a lot, or surprised me when I was there a lot, was speaking to individuals, which is like, yes, so of course everybody there we were seeing was men, but a huge amount of the men that we saw there were fathers separated from dependent children. And we really felt like this was sort of like not a narrative that was coming out at all. And then secondly, that people there were refugees. Our data very clearly showed that people were from refugee-producing countries, and they had histories that aligned with being a refugee. And also the countries that they came from were countries that, when you look at the UK asylum data, they're countries that there are very, very high grant rates for. Like our grant rate for people from Syria is 98%. So, you know, it was really important to show and demonstrate who the people were, to be able to counter the very strong government and media narrative that these people were not refugees and wouldn't have a fair chance in the asylum system. So we published the report. It didn't go entirely as we wanted to, but in some ways this was better. So just as we were about to publish it, the UK government at the time announced a general election. So for us, that meant, in the end, it was better. But for us, it meant that suddenly we had no MPs to be able to share the report with and to try and influence. They all just became candidates at that point. And also the media space was absolutely consumed with the election. But we still felt like it was important to get the report out there. And we did, so we worked quite hard to get media coverage, and we got quite good media coverage on it. The line that the press were most interested in were MSF opening up their first clinic in the UK, and the sort of media headlines were like, "War doctors open UK clinic," which was quite sensationalised, but we got coverage, so we were okay with it. So it was the first time that the sort of like true details of what was happening at the site, and particularly the level of mental health distress, we were able to coincide it with getting some government figures on suicide attempts as well, and I think that was really like quite shocking. So that was the first thing we did, and then we shifted our advocacy to the new incoming government, which was the Labour government. They had before they came into power, they said they would close the site at Wethersfield. They were opposed to it. The reality has been a little bit different, and the site still exists, so that has not ended up happening. But we focused quite a lot on trying to influence Labour. We had a long-term relationship and work with the main I don't know if this translates, policy think tank, the main left-wing policy think tank in the UK that is responsible for doing a lot of the policy thinking for the Labour government. They had started a piece of work about how to tackle the issue of asylum accommodation in the UK. So we worked with them, we gave them the data from the report, and they used it as a case study within it, and that the final policy recommendation is that large sites aren't used. I went to the Labour Party conference and carried out a presentation similar to this about what we saw at Wethersfield, and that enabled us to establish quite good relationships with, I guess, backbench Labour MPs. So there's a split, there's a division now that the Labour Party is in power. They don't want to close the sites. They are, this large site, they are under much more pressure from the media about other places where people are accommodated, which is largely hotels, and the media hate that and the British public hate it. So the government is promising to close hotels, and they're under much less pressure to close this site. So that's why they've kept it open. But we have been able to build quite a lot of support from backbench MPs who are not in the government, who continue to apply pressure and speak about the site in Parliament. And then probably the other main advocacy thing that we did was we used the evidence to submit a witness statement to a legal challenge that was being taken by 4 people who were at the site. There was a legal challenge that they were being held there unlawfully, and a couple of weeks ago we had the judgment for that, and 3 out of the 4 people, the judge upheld their claim that they were unlawfully held there. Sorry?
Thank you. I was just waiting for you to put your headset on. Thank you so much, Anna, especially for the last words that you've said. I mean, we can see that we're still fighting, that we're far from being done with the sites that are still opened. We know that we have people still in the streets or people still on the move, and I think this is something that you underlined really well in your report, this political willingness, back in the time in 2023, and hopefully this is disappearing, but to just completely eradicate the asylum right. You wrote it in your report. This is something they were against, and then of course this was for people that were tortured, that were traumatized, that had a very complicated migration journey. And so I might just say a few words to conclude before moving on. We still have a few minutes, Sophie, right, to just have a Q&A session for this roundtable. Maybe we have people that ask questions online in the chat as well. So thank you so much for your 3 interventions. And then we do understand that there are some common points in between your interventions. I mean, you all talk about how important it is to have shelters where people can rest, and with access to healthcare as well. We know that it's a lot of the time these are people on the move, right? I think we can also be very proud of what we offer, whether it's in Briançon, whether it's in England, next to London, and also what we offer in Paris. I mean, I think we're being very innovative in the way that we're trying to respond and help out when it comes to this trauma. And of course, not everything's perfect, but as you said, the support that we provide is essential. And it's essential, especially because people live in very dire conditions. You also said that some spaces are being created, and I mean, I've learned a lot from you today, and I think that people that will read your respective reports will be learning a lot from you as well. You know that the repressive measures are building deliberately spaces that go against what humanity can bring to the table, or what we can actually provide or bring to migrants. And I think, all of the spaces that you've described, those are political spaces, humanitarian space. I think it's really important to take that space and to keep on working. We're also not doing research in complicated political contexts. It's extremely hard. So thank you so much for your work, because when we listen to you, I mean, we know that it brings so much hope. So thank you for that.
On va pouvoir passer aux questions. La traduction marche bien?
Is translation working well? All good for you? Okay, perfect. So we're going to move on to the Q&A session then. So before I get anyone raising their hands in the audience, we have a question in the chat for Daphne. So Didier Fassin has worked in the same theme and in the same area. How did you maybe worked based on his work? How did you include it in your work? Very good question. Didier has done a survey on 5 years, so 2 weeks in the winter and 2 weeks in the summer. And with Anne-Claire Desfossés, she's also a sociologist. They published a book in 2024 regarding this ethnographic investigation, which to me is extremely interesting. And so he's worked with police forces, for example. He's been able to do some interviews with police forces. And I think I can complement his work, maybe regarding the outreach programs and, with activists that are not from MDM. And I think also I can complement his work regarding the law, because I think this is quite specific in Briançon. This isn't something that he's talked a lot about in his book. So this is, probably something that I can bring to the table. But we did meet actually in the field, and I guess that's it. Thank you, Daphne. We don't have any other questions online. I don't know whether we have questions in the room. Any questions for three speakers of this first round table? You can ask questions in English. If you're an English speaker, absolutely no worries. Thank you. Can you maybe introduce yourself? I am Daniel. I'm a nurse, and my question would be to Camille regarding the mental health resources for people living in exile in Paris. So there are three things that came to my mind during your presentation. There is a trend when it comes to participatory health centers. We have more and more healthcare staff members, and I don't think we use them as much as we could. And the second point is that when you said that we are lacking resources for these people, right? And in my experience, I've been working for 12 years in La Goutte d'Or, and we were talking about different sectors, and it was quite fragmented. And I was wondering whether, this is part of your advocacy work. I mean, we do have services that are provided, right? This is something that we go see people and we're very close to them. But if you're always on the move, this doesn't work. And my third point was regarding healthcare. I mean, psychiatrists are in the second area, and psychologists are hired directly by people working in the center. So I think it was quite interesting to just mention that. Thank you. I mean, it is true when we talk about, the landscape here. It's not, of course, this is something that we can add to, and everyone can add to this so that we know exactly who to refer patients to and where to refer them. So regarding the organization, it is true that we talked about referring, to public services, but we can definitely refer them to colleagues, to independent colleagues. And here it really depends on whether they're part of the convention, so doctors that charge an extra fee or not. So we do have a network in which we have different people. For example, we've got psychologists that agree, that are, they are committed, right? This is not a majority of them, but I think for MDM, for example, sometimes there is this paradox that we observe. That is to say that the mission is not meant to substitute anything. We're not meant to replace, I think, to refer people to independent colleagues. But I think it is also necessary to have a sustainable project here, because this program is extremely important. But if you look into it, this is quite paradoxical, right? Because the idea is to work on advocacy and to make sure that we try and get what we need, so to raise awareness. And at the end of the day, because this isn't working, we sort of have to, replace other professionals. I don't want to talk too much, sorry, but of course, when it comes to sectors, this is what you mentioned, that, people are always on the move and it's very unstable. I mean, of course, this makes everything more complicated. And what I've noticed that this argument of having different sectors, this is something that could be used for people living in exile and being in different centres. And I'll just stop there. Thank you, Camille.
Ah oui, très bien. Il nous reste 13 minutes.
Oui, bonjour Antoine Lazarus. C'est une question à Camille aussi.
I also have a question for Camille. So mental health at MDM has always been important, and when we want to talk about it, it's really hard to know where to start. So in what you said, Camille, there are two things that are quite impressive, and we see that with Primo Levi, for example, because MDM is linked with Primo Levi. So, you know, this is a trauma clinic. And so what you're saying is that we need to be very cautious. So we have to defend our projects, but not too much. Because once we just open that box, you know, people have to go through their trauma again. We take care of them, and then we let them go back to the streets, basically. So we have to be very cautious when it comes to the clinic. We need to make sure that this is some sort of a superficial clinic. That's what's being said, right? So when can we go further once people stabilize, maybe? So this is the first part of my question. And the second part of my question, I mean, I'm not going to say this is taboo, but you said that we need to follow up with people in the longer term, right? And since the very beginning, at MDM, we were told not to follow up with people in the longer run. I'm thinking of Bordeaux, for example, you know, doctors that wanted to have long-term patients were sort of put on the side. So does that mean that we're supposed to be changing the way that we see things now? Should we do things differently? Shall I answer now? Yeah? Thank you for your question. I think it really resonates with you know, my own questions. As I've mentioned, I am not a healthcare professional, so I'm only making observations here. However, when it comes to being cautious, especially for traumas, maybe two things. First, of course, this can be understood as a superficial approach or treatment, but I think that it's not because we're not treating traumas that there isn't any good effect on their mental health, right? And so on their capacity to live with their trauma. I mean, we're not saying that there is no care here. Of course, they're being cared for, but I think it would be better to be supported in all dimensions so that people can, you know, keep on living with their PTSD and be able to sort of handle it. And I would say that what's specific to this MDM's program for people living in exile or in dire poverty, you know, as I was saying, the current living conditions are something they always talk about. So healthcare professionals, they're always healing symptoms or, you know, treating symptoms that are going to repeat themselves because the origin of symptoms is a political and social origin. And so this could be, you know, something that is a problem for us, is that we know that we won't be able to just accompany them all the way. I mean, we can support them. I mean, of course, there is nothing that we can do on the trauma itself. I mean, the trauma is still there. It's not some sort of past trauma that we can try and fix, you know, right? How can we just try and put it somewhere in your memory? You know, it's always there. They're always in their trauma. And so what can we go further? I mean, of course, there are initiatives that were implemented. I'm thinking of Primo Levi, of course, that are really focused on psychological traumas. But even these facilities are saying, you know, we have to be cautious because we know that the living conditions are just not helping. And this is probably what we can think about, because we could think, you know, well, after all this continuous consultation centers are meant to always be there. And I think this, this goes back to the second part of your question, where we're saying that it's important to follow up with the people in the longer term. I mean, should this be a practice? Should this be our philosophy? But this is something that we need to think about for sure. From what I understand, therapy for mental health, this is about also people building back their confidence, building back their trust of people. And we're talking about people that are always on the move, that cannot create relationships, right? It means that you're going to be referred back somewhere else. You're going to be taken care of by someone else. And so here, I don't know what it means in terms of time, but when it comes to, of course, creating this therapeutical relationship, this trust, and having this continuum of care, I mean, that seems to be a good idea. Yeah, maybe just one question or a comment, that MDM is not against having this continuum of care or being able to implement care in the longer term. I mean, we don't want to replace anyone or substitute or be the substitute of anything or of anyone, but if you have initiatives or facilities that are in charge of mental health, well, we want to refer people back to them, of course. But then if there is a need to have this continuum of care in a place, for example, or in a context in which there is no other solution, then in that case, we will be there. And we will keep on offering and providing these services. You've also mentioned this shelter idea, right? This rest, these areas where people can rest at some point, right? But this is something that we've been knowing for the past 20 years. I mean, in 2012 or 2015, we've had loads of people arriving in Calais, for example. And we were doing a lot of advocacy work with the Secours Catholique, MDM, a lot of associations or organizations that were working over there. We were always talking about this, this rest, this shelters, especially from Menton to Marseille to Lyon. We wanted to keep in mind that it was important to listen to people that were on this journey. And I was wondering, do you have observations that you can make 15 years later or 20 years later? We know that people living in exiles were sent back to centers from Calais. It didn't really work because, the centers were not ready. The accommodation centers, I mean, they were not ready. They were a bit afraid. People were afraid to just go to these centers and then being sent back or expulsed from these centers. So, these shelters, this is not new. How can we make it more efficient? Who wants to take that question? Who wants to answer to Jean-François? Or no one? Who knows? It's true that, this shelter aspect, this is something that we're trying to develop as well with workers in Bordeaux. This is something, it's a bit more temporary, but Camille, if you want to say something. Well, very quickly, so this is, for these respite centers, these shelters, and this is something that we've observed already in the past, is that it's not only about having a location, right? I think the space is more of a respite center. I mean, of course, we need a roof, we need to have walls, obviously, but this isn't the only thing that we need. And this is why this is important to have this cross-disciplinary approach here, is that we need to have people, we need to have trust, we need to have some sort of a bond here so that people can properly just rest, that they don't have to be hyper-vigilant all of the time. But this is, very brief answers. I mean, we could probably talk for hours about this. One more question, because we have a couple more minutes. Perfect, I'm the last question. How lucky I am. So I'm part of the donors committee, and I was wondering, what is your relationship with the neighboring people, with the neighbors, basically? I mean, it probably has a huge impact on your programs, whether in Briançon or in Paris. you talked about these urban furnitures being set up all over the city. So I guess this is quite complicated. Do you have any strategies that you're able to implement? Daphne? I think this is also a question that is definitely something that Anna might be faced with in the UK. So very quickly, in Briançon, before having people coming through the mountains, back in 2016 or 2017, we had this CAO. So people were arriving from Calais, right? And so the foundation of Tous Migrants, All Migrants, this is exactly when we created this. So this is a welcoming and orientation center for the CAO. So as opposed to other places, such as the one in Calais or in Menton, we have a political environment that is quite different. I mean, back in 2020, the party of the is more on the right when it comes to the political spectrum. And I think that Génération Identitaire at some point was replacing police forces, trying to control people in the mountain by themselves. So these are part of the issues that we've had, but of course we know that the extreme right parties are just on the rise at the moment. So we don't have any hostile protests at the moment. So that's good. That's a good thing. But yes, this is a very unstable, right? We've got all of the associations, Tous Migrants. They're all here. They all work, and they're trying to debunk all of these myths that we hear about. And the idea is to really try to maintain some sort of truth on who are these people, crossing the border here. Thank you so much, Daphne. Anna, maybe talking about neighbours in the UK.
Yeah, it's a very interesting question. So in Wethersfield, very mixed. For some background, Wethersfield is it's a very affluent, the most beautiful, picturesque, rural English village, very white. So there has been certainly some hostility about there being the camp, so many young men there. It's not safe for women to go out anymore. House prices have become so low you can't sell your house anymore. So certainly some hostility, but also some positive reception as well. And I think this was one of the subtle benefits of us being there as well. Our medical team was based in London, so we go out and stay in Wethersfield for 3 nights a week. And the practical place to stay was in the local pub. The landlady was very supportive and receptive, and it meant that 3 nights a week the team, and sometimes I was there, we would talk to people in the village and have really good conversations. And I think just a little bit, it was one of the things that sort of like helped to kind of like humanize the men there. And we would start to get people in the village saying like, oh, well, I could come and volunteer at your clinic, actually. It actually was the pub landlady who started off this narrative about like, can you believe MSF have had to come into the UK? We never liked that narrative very much because we'd been in the UK for 15 years. But so actually some support and growing support, and probably I will finish with this, but a sort of like interesting thing that we noticed is that in all other locations in the UK where these large sites were set up, those locations would become targeted by organised far-right groups in the UK. So people who were not from that area, far-right organisers who were not from the area would go to that area and spend a weekend there, hanging out in local spaces, putting flyers on people's cars, sort of scaremongering about the site that was going to be opened up. And they tried to come and do it in Wethersfield. They came on, people from all over the UK came to Wethersfield, and they went around the whole village and put a paper flyer on everybody's car about all sorts of myths about the site and what it was going to mean. And the local villagers basically saw them off. People challenged them, and there was a really strong local, so I would say not so much support for the actual men, but there was a real desire from local villagers that they were not going to let the far right come into the village and mobilise people within the village. So that was quite an interesting difference.
All right, so I guess the idea is to open pubs in France so that we can recruit new volunteers. That would be one of the things that we can do. Maybe Camille, if you want to say one more thing regarding. No, sorry, we no longer have time for this. So Camille won't be able to answer that question. So thank you so much for your attention. Thank you to our three speakers. It was extremely interesting. And I think that we have a coffee break, if coffee has arrived. Has it? Coffee's here. Perfect. So we have a break until 11:30. Thank you so much.